Hello, everyone, and welcome to this presentation of Let's Talk, presented by the Visiting Nurse in Hospice for Vermont and New Hampshire. I am your host, Anthony Knox, and I am the Community Relations Manager for the VNH. And for this presentation, we are going to be talking to our home health program, various members of the team to discuss all of the different aspects of home health services that are provided by the VNH, which includes skilled nursing and occupational therapy and physical therapy and all kinds of different facets of the program. So we are joined by several members of the team to be able to talk about all of the different parts of our program. And so we're going to go round robin and start introducing all the different people. So we'll start clockwise to my screen. And Ericka, please introduce yourself.
Good morning. Anthony, thank you so much for having us. I'm Ericka Bergeron. I'm the Director of Home Health. Pleased to be here this morning with my colleagues here. I have been with the VNH just shy of 3 years. I spent my entire career at Dartmouth Hospital, and so now learning this home care world and being part of the continuum of care has been a great change for me, and certainly exciting to see how patients receive care in their home. So excited to be here this morning.
Awesome. Thank you, Ericka. And Jean.
Good morning, Jean Wolpert. I'm the clinical manager for the northern area of the VNH. I oversee services for the patients, managing the entire clinical staff of nurses and therapists, home health aides, and I as well spent many years at Dartmouth, but prior to that was in home care in New York, and then returned to home care here in the Upper Valley about 5 years ago with the VNH.
Excellent. Thank you, Jean. And Nadine.
Good morning, everybody. I'm Nadine Nelson, clinical manager for the southern part of home health. That keeps me on my toes. I started here a little over a year ago, also coming from the Dartmouth Hitchcock Medical Center, but now we're part of the Dartmouth Health System here at VNH. Same as Jean, overlooking a multidisciplinary team for the patients in the southern area. And it's great to be here at the VNH and share with everyone today.
Awesome. Thank you, Nadine. And Lori.
Good morning. I'm Lori Cummings-Bowen. I'm a team assistant, one of them in the north for the VNH. And I came here 6.5 years ago. I was in management working with people with developmental disabilities for 30 years. And I decided that I wanted to make a change to a position that gave me a little more life at home.
I hear that coming from a agency similar to that prior to coming here. So, and last but not least, Nicole.
Good morning. I'm Nicole Livingston. I'm the patient access manager here at VNH. I oversee the intake and now our team assistant program. I started with VNH actually as a brand new grad about 16 years ago and working my way up, and so kind of left and came back, and so I've been back now for 6 years and had been doing triage and now in this position as patient access manager, and just love seeing how things have evolved over the years. So looking forward to this conversation.
Awesome. Thank you so much, Nicole. And thank you all for joining us for this Let's Talk presentation. So I think what makes the most sense for a presentation like this is to just kind of talk about, home health overall and how it fits within the organization of the VNH. And so, Ericka, I'm going to let you take it from there.
Great. Thank you so much, Anthony. So yes, so home health is one of the 4 programs within the VNH. The VNH, of course, is a system partner to the Dartmouth Health System. One of the great advantages of being part of the larger health system is we share many of the supporting systems within our organization, such as our medical records. So we are our own organization, but linked within the larger system, which has many benefits. So within the VNH group, we have 4 clinical programs. So there is our long-term care program, our maternal child health program, our hospice program, and I'm going to call it my favorite, home health is the 4th program. So within the home health program, we have about 400 patients that we serve on an average day within 4,000 square miles, so a really large territory, all the way from like the Newbury, Vermont area, all the way down to the Massachusetts border, again, on either side of that Connecticut River. So many, many towns and a vast area that our team serves. So within home health, as Jean and Nadine shared, they're refer to themselves as the North and South managers. So we split our large territory into 2 sections. So we have a northern team and a southern team. And within those teams, then we have smaller cohorts of teams that really individualize and center on the patients that are in those areas. So that's kind of the big picture of who we are. And how we fit within the organization. As I said, there's 3 other clinical programs. So we do at some times interchange with those other programs. So for example, if a hospice patient needs physical therapy, or if one of our maternal child health patients need home health aid services, we do sometimes partner with the other programs, but our primary focus is on our home health patients. So what is home health then, right? So home health, the best way that I can think about it is a comprehensive healthcare services where you heal best at home, right? So traditionally, you may have received what I call skilled care at a hospital or an outpatient setting. But really, our mission is to provide those very skilled services within your home. Again, separate than some of our other programs where it doesn't necessarily require a licensed individual to provide the care. In home health, it's really those licensed individuals that are providing that skilled care. So again, we provide a vast variety of specialties, and really, again, our goal is to provide that intermittent, so we're not there all the time, but go in normally a couple of times a week to support you on a short-term basis. So our normal length of stay is anywhere between 30 and 60 days, sometimes longer for certain diagnosis, but normally, between 30 and 60 service. The patients that we take on service, and again, Nicole will talk a little bit more specifically about the type of patients that we take, but we take patients, once they hit adulthood, we'll take anybody from, 18 on all the way up, as high as that goes. So whether that's a patient that's discharged from an inpatient facility or have been in the community and referred by their physician for some short-term needs, or really just the patient that just needs support to stay at home, we will come in and provide that holistic wraparound care to really make sure that you meet that goal of staying at home and regaining or recouping your health goals, whatever those goals may be. So how we achieve that is through what we call our multidisciplinary team. So we have different disciplines, different professions within our home health team. So we have what we call skilled nursing. So skilled nursing is comprised of registered nurses and licensed practical nurses. So they partner together to provide all that skilled nursing services, whether that's wound care or comprehensive assessments to notify your provider of how your clinical situation has changed. Many different services that the nurses can provide. And then we have our rehab team. So that's our physical therapist, our occupational therapist, our speech therapist, our physical therapy assistants who work closely with the physical therapist. Again, they're working from that rehab perspective. We also have our social workers. And again, thinking holistically on how we treat patients, not just on their acute medical needs, but really how do we holistically treat all of the needs that a patient may have. And sometimes that means bringing resources to patients, such things as Meals on Wheels or something similar to that. And then we also have our home health aid services. So those are licensed nursing assistants that come in and really help to provide that hygiene, direct care, to help supplement those patients that need support with some of those fundamental pieces. So with our about 400 patients that we have on service at one time, we do about 1,000 hours of patient care every week. So we are a busy team covering a great territory. And I'm really proud that this team can coordinate and come together and really provide the services to a unique patient population, a rural patient population, and there are many dynamics that impact what healthcare looks like in our area. So I'm proud that we have all of these resources to bring to our patients. I now want to turn it over and share what does that journey look like. So you know a little bit about how we fit into the organization, the care that we provide. I really want to get a little bit more specific now and turn it over to Nicole, our patient access manager, who's going to talk a little bit about how patient referrals come in and how that, what I call the journey through home health, starts. So I'll turn it over to you, Nicole.
All right, thank you, Erica. So yeah, as you said, the beginning kind of the journey here is intake. We begin the process. That's when the referral sources reach out to us when they have a patient who's in need of home health services. The referral sources for us can often include, as you had mentioned, like our local community doctor offices, a multitude of the area hospitals, both large and small, and many even out of state. For your community referrals, you know, it's a lot of times, you know, just our patients that might need a little assistance here or there, a flare-up of one of their diagnoses. They might just need a little extra assistance, medication management, things like that. Sometimes just a new therapy evaluation. So those are some of the community referrals that we get. For hospital discharges, it could be like your post-operative patients, trauma cases that need to come out. We do a lot of communication back and forth with the discharge planners and the care managers. It's really the time for us to work on the specific requests that are being discussed and allowing us to make sure that we can accept the referral and meet the needs. As you had mentioned, Erica, we were able to make a switch in our electronic medical system, a documentation. So now we are part of the system partners program. So we are able to get things in a completely new way. Really, it's been nice because it's almost like a click of a button and we have everything ready for us. Often we're completed referrals to us before patients are even leaving the hospital or even the doctor's office, which certainly helps speed up the process. We also continue to receive our referrals via our electronic fax. We get them in a secured email system. Those methods are also helpful with these advancements because it's allowed us to get a much cleaner, better quality document with all the information we need to help build the referrals and provide the information to the clinical teams. So once we've done all of that, it gets handed over to our intake team. Kind of works to put it all together like a puzzle. We have to review it. They're looking to make sure that we have all the right pieces. Do we have the orders from the provider? Do we have all the insurance information, address information, medication lists, provider notes? If you've come out of the hospital, are we getting the information such as discharge summaries, operative notes, all the things that really help paint the picture for the clinical staff that will be coming in to help take care of patients. We, in intake, then go ahead and we review it all to really at that point make sure we are the appropriate folks to take care of you. Most times we can accommodate, you know, for our skilled services, we can do it, but some things we just can't. It's beyond what could be safely provided at home. And sometimes that means patients end up having to go to like a skilled nursing facility for a short period of time so they can get a little more intensive therapy and support, and then they'll transition to us. So it's been amazing over the last as I've dated myself to 16 years, to really see what has changed and how far we've come to the fact that now we're able to even take care of chest tubes and other things that I never would have imagined when I first started. So we really have come a long way. Ericka's kind of done a little bit of a talk here, but for the services that we provide, what is skilled? We have the skilled nursing, we have the physical therapists and occupational therapists. We also have speech therapy, which is nice, though she covers a broad area. It's been something that's difficult to get, and so we're grateful that we can bring that into patients' homes. If you have a skilled need, that's what qualifies you for home health services. You have something that's short-term goal. We are coming in to help, whether it is, like we've said, maybe a new diagnosis. You've been diagnosed with diabetes, so you might need a nurse to come in and help do some teaching and help you with your new medications, whether you're having to check your blood sugars at home, those kind of things. So it's something skilled that you need that licensed professional to help for a shorter period of time, and then hopefully get you back on your feet. The biggest piece for the skilled services is that our patients are what's considered homebound. So for the patients that we're seeing at home, they really can't get out. And that's what makes our services important. The regulations define it as being a taxing effort, and that it really, for a lot of our patients, it's that when they get out, it's just exhausting. It takes all day for them to go and recover from getting up from one appointment. So for them to be home and have us coming in really reduces the wear and tear and helps them heal rather than trying to get out to go see the doctor 3 times a week for that wound care. If you're a person who can get out easily, you can go run all your errands, then we probably aren't the right folks to help take care of you, and that's great because there's other resources for you. One important piece here too is that in order to have home health services, the patient does have to have an order. We love it when patients call us, but unfortunately that can't really get us started. So we do have to have a provider that's willing to send an order and saying that you do need our services. And that doesn't have to just be your PCP. It could be if you're seeing a specialist and they feel it's appropriate, they can send it as well. And we just need a provider who's willing to kind of walk through the whole home health process with us and be there to help the clinical staff as they care for you while you're at home. The other piece too is we often get a lot of phone calls. So we're getting patients themselves, like I said, will call in family members, friends. They're calling to inquire about what it is that we offer. How can we help them? And so part of intake is really being the detective and trying to ask the questions. What is it that they're looking for? Can we meet that need? And if we can, kind of guiding them in the right direction. And in those cases, sometimes it's asking them to have a conversation with their doctor. Unfortunately, there are times that we can't go. So where there's non-skilled services that are being asked for. So sometimes things like bathing, meal preparation, cleaning the home, those are not things that are skilled service and wouldn't fall under this bracket for home health. There are other options like private pay programs, long-term care, and then there's a lot of community outreach services. So the team does try to really help connect people. Even if it's not us, we really want to make sure we can get folks connected to the right place. I know for myself, it really feels awful to have to tell somebody they just don't qualify for services and there's nothing we can do. So trying to be knowledgeable about what's in the community and being able to give them a phone number, though you feel bad, helps give them a little relief because they're still getting something. So after we've kind of done that, I feel like we cover a whole lot right there. The final stage is the intake team goes ahead and takes all that information that we've received. We input it into our electronic medical record. We make sure that everything is there. It's all the orders are all set, that all the information for insurance is now gone through to the right places. And they kind of click that button so that it can go on to the next part of our team. So we've gathered all the pieces, we've painted the picture, and now we're sending it off for the team assistants to go ahead and start that scheduling process to get the patient on the next part of their journey. So I believe that next part of the journey is you, Lori, right? We hand it off to the team assistant.
Yes, it is. Thank you, Nicole. I did want to just start with that I've already said that I'm the team assistant, but there are 5 of us that support the home health and hospice teams. We primarily work 7 to 4 or 7:30 to or 8 to 4:30, and we do work 7 days a week. We rotate our weekends and our holidays, and once the intake department has got the referral in, then we take over and we will make the initial phone call to the patient and explain our services, and we will ask them if they would like our services, and if they do, then we'll go through a verification process with them, and we will be verifying their contact information, and then we will go through safety questions to make sure it's going to be a safe environment for the clinicians to go out when they do their initial admission for our services. And we have a script that we follow, and at the end of the script for me, I always end my conversation with the patient that we look forward to helping you heal at home. And it's almost like I can see or feel the smile on their face when they respond with, "We look forward to that too." And then after that, the clinician will go out and do the admit for our services. And then once they do that, then they will put in the orders for the patient's visits. And then we pick it up again, and for however many visits a week, we will get them scheduled. We call the patient and ask them what days work best for them, whether they're being seen twice a week, once a week, and so they're a part of what days they're being seen by who. Sometimes it gets a little tricky when we have 3, 4 different clinicians going in to be able to spread the visits out so that we're not tiring the patients out. But there are times that we may need to have 2 different people going in on the same day, but we try not to do that. And let's see, and throughout the day for a team assistant, we're continuously answering phone calls. We're speaking with patients about their visits. We're canceling visits for clinicians or patients, and we're transferring people to triage nurses when they have an urgent need that they or a health concern that they feel like they need to talk to somebody right away. And regardless of why they're calling us, we are always there to listen. The team assistants will always listen to whatever they need and get them to who will best support them. And for me, patient-centered supports, I feel like the team assistant is in the middle with the patient, and that we are working from the inside to the outside to help get them the support that they need, where the clinicians are working from the outside to the inside to the patient to give them the best support and help them to heal as quickly as possible for them. And I think that's all I have. I don't know if I did my whole time, but now I'm going to pass it off to Jean to go through the journey for a clinician once we have got the patient set up to be seen by the clinician.
Thank you, Lori. So I'm going to speak about the day in the life and the journey of the patient through our services. And we look at our services as an extension of your hospital care. Our care is of short duration, 30 to 60 days. You do have to be homebound, like Nicole said. Homebound doesn't mean that you need to be strapped to your house. If you're capable, you can go to the doctors and see your appointments. But as she suggested, it has to be a taxing effort. So it has to be difficult. You need assistance to get out of your house and to get to those appointments. And that's what would make you eligible. Our visits are for a short period of time. Most visits are about 45 minutes to an hour, and they are all pre-scheduled. As Lori suggested, she calls for the admission visit. That would be our first clinician in. That visit takes about 2 hours. And after that, then the other clinicians that may be on the team will go in for evaluations. Those visits last 45 minutes to an hour. And then recurring visits then last about 45 minutes to an hour. As Lori said, they do schedule these visits out with patients to their liking, knowing that things come up, lives change, you have different doctor's appointments and so forth. So our clinicians call sometimes the evening before or the morning of the visit prior to 10 o'clock to set up a time and make sure that everything is still copacetic with the patient for their visits. So it's really important that our patients answer their phones. Sometimes our phones come through as 800 numbers, and we understand everybody screens their calls. I don't answer 800 numbers either. So, but I do listen to the message that they leave on my answering machine, and then I'll return a call if it's appropriate. So we do ask that of our patients also, so that we can verify that they are available for our scheduled appointment and that they are agreeable to the time that the clinician is now suggesting. Admissions can be done by skilled nurses, by physical therapists, or by occupational therapists. And that's the visit that is the initial visit. We'll go over, it'll be a full extensive assessment. We'll go over all of your medications to make sure that all medications are in the house that the doctors have ordered. And then we'll set up your plan of care. And how we're going to follow this to get you back on the road to where you were previously, or maybe even better. So we'll look at what your goals are as a patient, excuse me, and then what our goals are as healthcare clinicians to try to get you to that ultimate spot. So everyone is treated as an individual. It is expected that your spouse, your family members, your friends, anybody who you feel is available to help you are enlisted to help with various types of care. A lot of people need help with doing pill planners, their weekly pill planners. And maybe the patient can't do that themselves for various reasons. But we want to look to see, okay, who's going to help you do this? Because again, we're a short duration service. So we're only going to be there for about 30 days. And who's going to help you with that afterwards? So we're always looking to see who is available to help you with those supportive things. Again, there's some other things. You're a diabetic, you need your glucose checked, you may have a small wound that needs some care or attention. So those are all things that we look to teach a spouse, a family member. Sometimes even the patients are educated to do self-care with these things. As I said, the first visit, we review medications. So it's very important that you have all the medications that have been ordered for you to have them at the house so that this review can be made and that we know you're taking the right medications. During this initial assessment, we also look for home safety issues. So you're a person who lives by yourself? Is there someone who checks in with you daily to make sure that you're doing well? That God forbid you haven't fallen on the floor and are still there. We make suggestions about the lifelines, about having a friend call to check on people. So we look at all of those different aspects. Home safety also includes all the lovely throw rugs that we all like to have all over our homes. Are they really in a safe location? And is it good for you to continue to have them where you have them? Is that your main walking path? And can you trip and fall on them because you now are walking with crutches or a cane or a walker? So it may be something that's very different to you. So we may be asking you to relocate them permanently or temporarily. One thing that's really important is, what are the patient's goals? Where do you want to go? How can we help you to get to where you want to be? And this is something that we ask patients over and over again. Our goals, of course, is to bring you back to phenomenal health. But maybe you don't want to do all that is entailed with that. I think a great example is one of our colleagues had knee surgery and isn't interested in playing all kinds of sports and everything else, but wants to be able to kneel down without pain. So the therapist worked with her to get her back to that particular state of health, that she's able to kneel without pain and do what she wanted to do. Now, maybe the therapist had other ideas, that she should be out running and playing tennis and everything else, but that wasn't her goal. So clients' goals are extremely important. It's also important that the clinicians have goals and that they're shared with the patients. And explanations of those goals are important. So a patient may be a diabetic for 30 years and now has a wound on their foot. Well, it's extremely important for us to readdress the diabetes and the healing process and maintaining good blood sugars and taking their medications regularly and watching their diet and getting their sleep, because all of those things help with good healing of those wounds that they may have. So it's important that clinicians have goals, but they have to be able to meet the patient's goals as well, so that we can get the patients to their ultimate best health. Physical therapists go in and they see a lot of orthopedic patients, so post-operative patients, and they'll see them for 3 to 4 weeks until they can get to outpatient therapy. In-home therapy is great. They can give you exercise programs and build up your endurance and your strength. But going to outpatient therapy, you have all of the equipment and all of that can be added to this to even build you up more and to a greater level of ability. So they go in, they give the programs, and they really do suggest that you get busy with getting to outpatient therapy, because it's really important. It can give you a bigger lift than just home care. OTs, or occupational therapists, go in the home to support with ADLs, activities of daily living. Are you able to get in your shower safely? Should someone be putting safety bars near your shower or near your commode to help you with standing or moving? Do you need a shower bench or a shower chair that you can sit on while you're taking your shower? And excuse me. They also enlist the help sometimes with home health aides. So home health aides are brought in to help maintain your ADLs in a somewhat regular manner. They'll help with showers and bed baths and so forth, according to the patient's ability. But they also help in conserving energy. So if you've come out of the hospital and you're weak from surgery and you're just home, we suggest that we bring a home health aide in to conserve your energy. Let them help you with some of these things a couple of times a week so that you can use that energy to do something else to regain your strength and move back to the position where you were prior to your hospitalization. Home health aid services are only once or twice a week usually. And then as you get stronger and more capable of doing things, then we move to once a week and bring it down to that the home health aides are finished before we discharge patients, so that we can see that the individuals are strong enough to care for themselves during this time. Speech therapy is also available. So we all know speech therapy, or we think speech therapy is just to help patients talk again, where in fact she goes in and she can look at and treat patients that have problems swallowing while they're eating, and teach them different methods to help them with their communication, but as well as their chewing and their swallowing abilities, the diets that they should be on. So she has a vast knowledge to help with that particular area. We talked briefly about our medical social workers, and we use them tremendously for support with community information and support information to obtain additional help with transportation to doctor's appointments, sometimes with housing, with obtaining food, Meals on Wheels, things of that nature. So the medical social workers are invaluable to us. They help us every single day with multiple patients to get them to a healthy spot. So how do we provide multidisciplinary services? As Lori said, sometimes it's really difficult when so many services are in, but we do try, to have only one service per day go in and visit someone, because we're not looking to wear somebody out or tire them out. We're really looking to help them and support them to get to a healthier state. So that's the first way that we look at this. We also have team meetings with the entire team once a week to discuss patient care, particularly multidisciplinary patients. And how are you treating that patient and what are you doing? So that sometimes our services overlap a little bit, but we don't want two people going in and doing the exact same thing and not moving forward with other duties. So we do have conversation. They're great conversations because they can share what's happening with the patient so everybody knows. And then they can all plan their care accordingly. We sometimes do make joint visits. The occupational therapist will go out with the home health aide to work with the patient for shower safety. So sometimes it's for different education that the occupational therapist may want the home health aide to do something a little bit differently. And that goes along with PT as well. So we'll see physical therapists and occupational therapists occasionally going out together so that they can create the best plan for that individual. We also have physical therapists, and I actually made the suggestion this morning that a physical therapist go with our skilled nurses. We have a client who has a wound in a difficult to reach place, and how best can we help the nurse not hurt themselves in caring for this patient? What equipment can be ordered and for the patient to help us provide that best care for the patient. So we do work every day as a multidisciplinary team for, I would say, the majority, if not all of our clients that we currently see. And I think that just about covers all of it. So I am going to turn it over to Nadine, who's going to talk about our triage services and our revising our care plans. Thank you.
Hi, everybody. Thanks, Jean. That was very thorough. And I'm going to talk more about the triage offer and the coordination of care with the PCP and, some of the referring providers and agencies in the area, and then how we do some revisions on the plans of care. So our services are 24/7, specifically for nursing. Our case managers go out from 8 to 4:30, Monday through Friday, and over weekends as well. We have some rotating shifts for that. That's for nursing and for therapy. And then we have wonderful triage nurses Monday through Friday who help in real time with the clinicians out in the field. So that's really helpful for patients. If they need to call and they have something going on, they can get triaged to the real live triage person, which is wonderful. I kind of sort of call our Monday through Friday triage nurses a lifeline, just like our team assistants, which is wonderful. And then from 4:30 until 7:30 in the evenings, we have on-call nurses for the North team and the South team that help support any in-field things that need to occur that are emergent. Obviously, if it's something really urgent and there's nothing that we can do for some of our services, it may end up being an ED visit, although we do our best to try and deter that from happening and triage that over the phone or out with the patient. And then from 7:30 until 7:30 the next morning, we actually have a triage company of nurses that we outsource. And those calls, you can call the main line and still get a nurse on the other side of the phone who will help triage that. We have a couple of hospice nurses on call overnight as well that help mostly with the hospice patients, but they're wonderful about helping with any other situations that may occur. And then we have an administrator on call as well who oversees that. So if there's anything really urgent or emergent going on, there is always somebody in the background to help support that. So I would say we have 24/7 nursing services, most of them in real time during the day. We have a wonderful group of core nurses, and then we outsource and have some travel nurses too. And then for our therapy services, we have a great core group of therapy therapists, and we also outsource travelers as well to help us in the background, which is amazing. Our travel nurses and therapists are exceptionally wonderful people who have a wealth of information, and it's great to resource them to try and see how they do different things in agencies and can help us look at things from a different perspective as well. We also have clinical nurse leaders, and I wanted to bring those up in this group today because we have two of them for home health, and then we have one clinical nurse leader for the hospice team. They are great at looking at complex patients, following the patient journey from admission to discharge. They also keep track of our patients who may end up in the hospital, and we always look back and see how we could have maybe prevented them from ending up in the hospital. Sometimes you can't, but we're always looking at those quality and safety metrics and measures in the background. And so they really oversee that piece, which is amazing. They are master's prepared nurses, and I believe we're one of the first agencies to have that in home health. So we are very proud of that piece. And they add so much value to our teams. They add a great amount of value to our patients too. So I just wanted to bring them up and honor them as part of this team as well. In terms of coordination of care with the PCP and referring providers, so upon the start of care or the admission for the patients, we always work collaboratively with the providers and referring providers. If anything else new has popped up or we're not sure about an order, or if there's something else going on with the patient that we did not see upon admission, we share that openly with them and collaborate to see how we can holistically treat the patient. And like Jean and everybody else has said, it is definitely a team effort. It's not just us as clinicians coordinating that care. It's also patients being a part of that care and the providers, care providers too. And working together as a team for your goals and our clinician goals as well, and to make sure we have good patient outcomes and that everybody is happy at the end and that we have a good baseline to work from as well. And then in terms of, we have the plans of care that Jean did talk about. We can start that upon admission, but those are ever changing. So we don't want to just have one plan of care, say for wound care, and there could be something else that pops up along the way. There may be a huge change in medication, might be a CHF patient or a congestive heart failure patient who has constant medication changes, and we're monitoring that. So those plans of care are consistently changing with the flow of what's going on with the patient at the time. That requires a great amount of assessment and communication between clinicians, patients, and the providers. And we're consistently communicating with each other to make sure that we do meet those outcomes for the patients. I'm really proud to be a part of this agency. I've been here for a little over a year, and, just listening to this today and, Nicole and Ericka, Jean and Lori, and how we all have our slice of the pie to try and help patients holistically and treat them as a human being, no matter who they are. I'm very proud to be a part of that. And I'm going to put that back to Ericka.
Well, Nadine, you stole the words right out of my mouth, because that was the same thing that I was going to say, was just that. I am very proud to work with this team. I feel honored to be the leader of this team. I couldn't do what I do without certainly the leaders in this room, but also our entire clinical team. We have about 60 clinicians out there in the field every day providing this really, really great, vital care to our community. So you see 5 of our faces from home health today, but there are many people out there providing this care and being so committed to patients reaching those individual outcomes that they want. That again, I just feel honored to be part of this group and the evolution of the VNH home health team. So I will say, I will add one last piece, and then I want to make sure that we have a minute to answer any questions. But I am really proud to say that 93% of our patients upon survey recommend the VNH services to their family and loved ones. To me, that's a really great sign that when we are committed to your care, when we are partners in your health, you achieve outcomes and you're satisfied with the services that we've provided. So we as an agency are very lucky to be partners in your care, and are thankful that our outcomes help support you and you are satisfied with what we have done. So I will end this with great appreciation for the people that are in this room, and again, they are helping to lead the teams that are providing this care every day, but we certainly couldn't do it without our clinical team. So thank you, and I will pause now, Anthony, if there's any questions out there, or if we can clarify anything.
Yeah. Well, so for those watching live, if there are any questions, please don't hesitate. I will say that as we were going through, we're writing questions down as things were being discussed, and then the next sentence out of whoever was talking's mouth answered that question. So, I think overall, just a lot of really great information, again, just a very well-rounded picture of where home health is able to provide the supports to the individuals that need them in all different, situations and settings and things like that. I do just want to include the fact that, Nicole and Lori, obviously a big part of the home health team, but also just a big part of scheduling everything, scheduling home health and hospice, and all referrals come into Nicole and her team, not just home health and hospice, it's long-term care, just everything comes in, to these individuals and to support. And, and again, while during the presentation, we're talking about North and South, it is still, one big team, and being able to provide supports across the board. And, obviously, because we're covering 4,000 square miles of Vermont and New Hampshire, we do try to, logistically, help those that are providing support not have to drive, 4,000 square miles to do all this support. So that's why we, break things up and things like that. But no, I mean, again, I'm not seeing any questions from those watching live. Anybody who's watching this presentation recorded later, please don't hesitate to reach out to us at the VNH. You can go to our website, vnhcare.org, and there are a bunch of different places to be able to send us in a message, and we all work together to get those messages to the right people to be able to provide the best answers possible for you or your loved ones as you're trying to find these supports for individuals. So with that, I will say, again, thank you, Ericka, Jean, Nadine, Lori, and Nicole for being a part of this Let's Talk presentation today. And again, for those watching live, watching the recorded presentation, again, don't ever hesitate to just give us a call or shoot us a message to be able to ask questions, to get clarification. We're, like several people have said, we may not be able to provide exactly the supports that you're looking for, but we do know of resources within your communities to be able to reach out to get those supports as needed. So, is there anything else from any of the five of you as far as any additional information? I will say you guys covered a ton of information, and so but yeah, no. So I want to thank you all for joining Let's Talk today, and thank everybody who is watching this to get this information. Thank you for giving us a little bit of your time to better understand the home health services that we provide. Thank you all, and we'll see you at the next Let's Talk.